Okay, so when we're talking about burns, and if you'll look at the didactic here, that I'm just going to pull up, really there's not a whole lot that you have to know about burns, but you do have to know like different types and the severity. And it says the burn depth staging and estimated body surface area, which is really the Parkland burn formula. And then it says conditions needed for wound healing. So we're going to try to look at that and see. What we can come up with, and then I will ask questions. But when you're dealing with burns, there's a couple things that I think is kind of important that they can be different kinds of burns. There could be like a dry heat burn, a moist heat burn, a direct contact with a hot surface, chemicals, electricity, radiation. All of those things can cause a burn. And so it says the type and severity of the burn affect the treatment plan. So if you were going to be a burn nurse, I know in Amarillo, I'm not sure which hospital is like a burn that you would send the patient to for burns, but I think they have to send them to Lubbock for the burn unit. So it says, in addition to destruction of body tissue, a burn injury results in loss of temperature, regulation, sweat, and sebaceous gland function and sensory function. When the dermis is destroyed, skin can no longer regrow over the affected area. So, one thing that's important to know is metabolism increases to maintain body heat as a result of a burn injury and tissue damage. So, every body system that you can think of is affected by a burn. Down here, and this is the older ATI, but I want you to look at yours. It just talks about the different kinds of burns, which I don't think that you are going to need to know the different kinds, but there's different severities of the burns, the burn depth, and I want you to see the percentage of the total body surface area, which is how do we figure that out? We're going to have to know that for the exam. And then how much fluid do we give the patient is going to be important in this, okay? And so we have to know how many layers of skin were burned and where the burn is on the body, like if it's the hands, the feet, or if it's a big percentage of the body. And if you look here, it says young clients and older adult clients have less reserve capacity to deal with a burn injury. Uh, Skin thins with aging, so there's more damage to the skin. And just like I said earlier, look, it could be a thermal burn, a chemical, electrical, or radioactive burn. It could be any of those. So, uh, one thing that I do think that they like to ask is about the respiratory system and a burn. There was a show on TV called This Is Us. I don't know if you guys got to see that or not. But one of the shows, I just remember watching the father had to run back into the burning house to get the dog, or he ran back into the burning house to get the dog. And then he came out, and then he was like covered in soot. His face was, had the smoke inhalation, soot under the nose. And when they took him to the hospital, his wife was visiting with him, and then she left to go do something and then come back, and he had passed away. And the reason why he had passed away is because he had inhalation injury. So whenever there's a burn, we think of the respiratory system. It's going to be important. Inhalation of deadly fumes, smoke, steam, heated air can cause respiratory failure. A lot of times we don't realize that when we're in a fire or a burn situation, carbon monoxide poisoning occurs. Now, the weird thing about that, and I'm just going to say this right now, I don't know if you'll get a question, but you possibly could, that when you have carbon monoxide poisoning, the O2 sat that you put on the finger still can show a normal oxygen. So it's very deceiving. You have to get a blood test. You have to get a carboxyhemoglobin blood test to see how much carbon is in the body or in the bloodstream. So I'm going to point that out that your oxygen may look normal, but you can still die. So when we look at this here, we've got different kinds of burns, minor burns, moderate burns, and major burns. And when we look, how they classify these is like the total body surface of the burn, right? You don't have to memorize this, but just know a minor burn would be maybe a full thickness burn of 2% or a partial thickness of 10%. So that's how they classify them. And if you look here at a major burn, well, obviously it says requires emergency treatment at the closest facility, maybe even transferred to the burn center. And clients who meet any one of the following criteria are considered to have a major burn. So there are criteria for this. So let's look here. They could ask how to prevent a burn. It is a possibility. And I'm going to look really quickly. It just says review the type, severity, injury classification. So let's look here. Types, injury, severity classification. We're going to go down here. Now, this is going to be important, I think, is the depth of the injury. So usually when you see a test question on a burn, it's going to give you like a scenario that says the dermis is damaged, the dermis down into the dermis. And so you have to think, is this superficial? Is this deep? Is this full thickness? What are we looking at? So this little chart is probably going to be pretty handy to you. One of the things that you will see in a superficial thickness burn is that there's just damage to the epidermis. And I want to point out, I think right here, if you look, it separates the layers of skin for you, which is kind of good. So in that superficial one, there's just damage to this top layer, this epidermis layer. Then there will be damage down into the dermis and to the sub-Q tissue and then the bone and the muscle. So we're going to classify it as, look at this. It just says this one's a superficial. If you look right here, it's very superficial epidermis. And then there's a superficial partial thickness, which has now gone down into the dermis. And then there's a deep partial thickness, which has gone way down into the dermis, almost not quite into the sub-Q tissue, but down further. And then we got full thickness, which I think is down into the muscle and bone, and then deep, which is way deep, like almost unstageable. So what we're going to look at is what I want you to pay attention to is when you have a superficial burn, what might it look like? It could just be pink to red. I'm going to say both superficial are probably going to tie together. I don't know that I would separate these for the exam, but if you just have a very superficial burn, it could be a little sunburn, right? Pink to red, no blisters, mild edema, no eschar, which just means no black tissue, okay? When we get to the superficial partial thickness, which is a little deeper, we might get some blisters. And that's what I think of as a superficial burn has blisters, mild to moderate edema, still no eschar. Now, if you look, this first superficial layer, this epidermis, is painful. The nerve endings are in the tissue still. And so a person who is burned on the surface of the skin, which is really the epidermis, or even down into some parts of the dermis, it will hurt. It will be painful. The healing time is about 2 to 3 weeks, and really no scarring. Look, it could be a sunburn, it could be a flash flame, it could be contact with a hot object. So what I think you need to know here is when you're dealing with a superficial burn, it's epidermis or down into the dermis a little bit. No blister or blister, and a partial thickness would be a blister. Now, when you get deep partial thickness, look what this says, damage to the entire epidermis and deep down into the dermis, okay? Let's see what it looks like as appearance-wise. Red to white. Now, that's different because the skin will turn kind of white. You would think it would be, more black. But it says blisters are rare, moderate edema, eschar soft and dry. So might have a little bit of black. Dead tissue is eschar. And then painful and sensitive to the touch because of the epidermis and the dermis, right? May have to have a possible graft there. And it just tells you some examples of burns, could be a flame or something that caused the burn. Now, when you get to a full thickness, I want you to think damage to the entire epidermis and dermis. So we went all the way down. Let's look at full thickness down into the dermis, all the way down in there. Now, what you don't see on this picture is there's the hair follicles, there's what do I want to say? Oil glands, blood vessels are all in this area. So when you're dealing with a full thickness burn, you're dealing with a really damaged tissue. And look, it says it can extend into the sub-Q tissue. I really do think they'll have it where, it says burn from the epidermis down into the sub-Q tissue. And if you notice that full thickness burn, there's nerve damage. And so one of the things they like to ask is you probably won't feel it, which is probably a blessing. You don't feel that because the damage to the nerves. The skin can look red, black, brown, yellow, or white. No blisters, severe edema. Anytime there's a severe burn, the body tries to send fluid in, which causes edema and the white blood cells. And then when we get to the deep, full thickness, look, it goes down into the muscle and the tendons. Still, it could be black. A deep, full thickness would be black, no blisters, edema. Eschar is hard and inelastic, no pain. So, one of the things they really like to ask is where, what kind of burn has no pain, really? The nerve damage, but this one has no pain because there's no nerves left in the tissue at all to hurt. And so heals within most weeks. So I would say this will be kind of an important thing. You may even see practice test questions on it, and we may even get one here in a minute. When you are on this exam, you're going to be dealing with something called the rule of nines. And here in a minute, I'll show you a picture and we can look at that. But what that is if you worked in a burn unit, it's a very quick method to approximate the extent of the burn by dividing the body into multiples of 9. The sum equals the total body surface area. So what they'll do is they'll say, oh, they're burned on one forearm and then the leg and whatever, and they'll get a percentage. And this percentage will figure out how much fluid to resuscitate them, to give them, because the fluid is going to be really important in a burn. Okay, we'll find that out here in a minute. Now, there's something that I have never seen before, and it said the Lund-Browder method, which said it's a more exact method, estimating the extent of burn by percentage of surface area. So probably a little more detailed, but I don't know that you have to know that for this exam. Just know that it exists. Palmer method, if we look at the Palmer method, it just says the palm of the hand, including fingers, is equal to 1%. So it just gives you a little bit of like another method. But the rule of nines is what you're really going to focus on. Now, I want you to see this, okay? When there's a burn, and we talked about the different kinds of burns, but when there's a burn, there's going to be an initial fluid shift in the body. Like I said, this person with a severe burn is going to need fluids, right? It usually occurs in the first 12 hours and continues for 24 to 36 hours. Let's look at some labs we would run on this patient, okay? A CBC with a differential, glucose. Anytime there's a burn, the sugar will go up because the body's under stress. And then we will have our bun elevated because they're dehydrated because they've lost a ton of fluid due to this burn. So those might be important facts when you're looking at a burn, but I want you to see hematocrit and hemoglobin are elevated because they're thicker in the blood due to the loss of fluid volume and the fluid shift into the interstitial space. So what happens is the blood becomes thicker, it's lost fluid, so you'll see hematocrit and hemoglobin go up. So sugars will be up, bun will be up, hematocrit and hemoglobin will be up. Now, if you look, it says sodium will be decreased because they're kind of third spacing. The fluid is not in a compartment, it's just kind of in the tissue. The potassium will be increased. It says due to cell destruction, and then the chloride is increased due to fluid loss. And I'm not sure if they'll ask that, but I do think they're going to ask you something about fluid resuscitation. Because when you have a burn patient, you've got to resuscitate their fluid because they lose a ton. And right here, you can see why these labs are off is because the fluid shifts. So within the first 12 hours and continues for 24 to 36 hours, we're going to be focused on giving fluid to this patient, okay? Now, a little bit ago, I said carboxyhemoglobin. Here's the word right there. Remember what I said, that when a patient has a burn injury, we also might see a normal oxygen level and think everything's okay, right? When we put the little SpO2 monitor on them, it might show normal oxygenation. But that is not the case, usually if a patient has inhalation injury. Um, Sometimes they'll ask a question that the patient has soot or smoke or like the soot from breathing in the smoke under their nares or their nose, which you would suspect inhalation injury if that's the case. So they would have to have a blood test to determine how much carbon is in their blood, and it's called a carboxyhemoglobin. It says more than 10% strongly indicates smoke inhalation. I think that's going to play a role on this test for you. They could also have what's called cyanide toxicity, which is a plasma lactate test. It's elevated if they have that. And then, but I don't know that they'll ask too much about that. One thing I do think total protein and blood albumin, ABGs, probably metabolic acidosis, liver enzymes, urinalysis, and clotting studies are all going to be important. If I was you, I would say fluid resuscitation, carboxyhemoglobin will be important. I I might even add the sugars will be up, the bun will be up, and the hemoglobin and hematocrit will be up. Um, Look what this says again. It repeats itself. Fluid remobilization starts at about 24 hours. The diuretic stage begins at 48 to 72 hours after the injury. So this patient is going to lose a lot of fluid due to this burn. And it actually repeats itself again here down below, like hemoglobin hematocrit, and it tells you why um, you would see the things that you're going to see. We already know hemoglobin hematocrit well, look what this says, will be elevated at first, I think, and then it says decrease due to the fluid shift. So we're going to see some shifts here, remain decreased during the renal wound loss sodium. I don't know that the didactic tells you that you have to memorize them, but I do think, just going into this test, knowing that the sugars will be up, you might see metabolic acidosis in this patient, and then protein and albumin will be low because they've lost fluids. So what are we going to do? I'm going to look, first of all, we're going to evaluate the burn depth. And the patient, they're going to, if you worked in the burn unit, you would be doing that. But for this test, I think it's going to be a little bit a different question. I want you to see that there are phases of burn care. Okay. So when you look at burn care, there's an emergent phase, right? Look what it says. This phase begins with the injury and continues for 24 to 48 hours. This is a very emergent time after a burn. So let's see what our priorities would be. Securing the airway, supporting circulation, and organ perfusion by fluid replacement. Fluid replacement is going to be important. Airway is going to be important. We need to know, did they inhale a lot of carbon, right? Their oxygen may show normal, but their carbon, we're going to have to do a carboxyhemoglobin on them. And we need to see how is their blood circulating, because truly, if a big percentage of your body is burned, so are your vessels, right? And you're not going to get that perfusion around the body. So another thing that's really important is maintaining body temperature and providing emotional support, obviously. Let's look at the acute phase. So there's an acute phase, and it says begins 36 to 48 hours after the injury when the fluid shifts resolve. So by this time, we should be able to stabilize the fluid, right? And then it says this phase ends with closure of the wound, but it could be a long time for that. So priorities include assessment, maintain the cardiovascular, respiratory, GI, wound care, pain control, and then psychosocial interventions. Let's look at the rehabilitative stage here. And like I said, I don't think you have to memorize this, but I just would say that within the first 24 to 48 hours, it's the emergent stage. If you look at the rehabilitative stage, the phase begins when most of the burn area was healed. This phase ends when the client achieves the highest level of functioning. So, look, this phase can last for years. This is not a quick, any type of burn is not going to be a quick fix. Okay. So, we're going to worry about fluids. We're going to, number one, okay. So, remember back at the first, I said there could be thermal burns, chemical burns, all kinds of burns, right? First of all, for nursing care, we're going to stop the burning process. So if they have a chemical on their skin, we're going to wash it off. We're going to take the clothes off the person. If providing care at the burn scene, extinguish flames or remove the source of the fire. Remove clothing or jewelry that might conduct heat. Apply cool water soaks or run cool water over the injury. Do not use ice. This might be important. Flush chemical burns with a large volume of water. Cover the burn with a clean cloth to prevent contamination and hypothermia. Usually what they'll do is have a clean sheet to cover the patient, okay? Provide warmth, and then it says perform the ABCDE primary survey, which you guys kind of had on the last exam that, airway, breathing, circulation, and then the other two. So for a minor burn, what do we do? Okay. It says analgesics, clean with soap. Don't rub it. Obviously, avoid friction. You can use an antimicrobial ointment, like Neosporin, I guess, and then apply, or it says ointment. Apply dressing non-adherent if clothing is irritating the burn. And then educate the family. Don't use greasy lotions or butter on the burn. Now, I know you guys, that could be a question right there. Never put any greasy lotion or butter on the burn. Years ago, it was an old wives' tale that if you burn yourself, you put butter on it. But that butter will add to the burn. So do not do that, okay? That might be somewhere that you need to know. Teach the family to observe for evidence of infection, and it says determine the need for a tetanus immunization. Now, I think that might show up on your exam. Whenever there's a burn, a lot of times people do not realize that you need a tetanus vaccine if you don't have a current one. They'll give you one anyways, even if it is current. You need to have a tetanus immunization. Okay. So here's our moderate to major burns, which is probably going to be the category you're going to be dealing with on this exam. And it says during the initial phase, and it repeats itself there, 12 to 48 hours following a major burn, look what happens. The sympathetic nervous system manifestations. And, we kind of have a few things on this exam that deal with the sympathetic nervous system. But think of the patient is going to send them into their fight or flight. Tachycardia, increased respiratory rate, decreased GI motility, and increased blood glucose are expected findings. I think I might want to know that. Okay. So we're going to assess respiratory rate, right? And it says monitor chest expansion. Check dressings on the neck, chest, and back. Do not restrict movement. Let's see, upper airway edema. Okay. Now, when there's the inhalation injury, we watch for the edema in the upper airway, but it says it can be pronounced 8 to 12 hours after the beginning of fluid resuscitation, like stridor, shortness of breath, nasal flaring, oral intubation. So we watch for airway edema. Provide humidified supplemental oxygen, and then it says we may even have to use a mechanical ventilator, right? If the oxygen is less, if the arterial oxygen, is less than 60, they may do a tracheostomy. Perform chest physiotherapy, which is like incentive spirometry, pounding on the chest. And then it says section every hour as needed. So really, I mean, if we're going to watch the respiratory system, the one thing that stands out to me is making sure that you watch airway edema And then you also watch that carboxyhemoglobin. And we look at the arterial oxygen because we're going to do an ABG on them. And if it's less than 60, we may have to do something to help them, like a tracheostomy. So let's look down here. Obviously, we're going to look at the cardiovascular system because it's what's putting blood out to the body. And remember, some of those vessels are burned. And so we probably will see EKG changes. And not to mention that, but if we go back up here, why would we see an EKG change? Is because the cells are destroyed and potassium is out of the cell now. And so it could throw the heart into a different rhythm. Just saying. Okay. Now, this is the biggie right here. I'm just going to tell you the fluid replacement you're probably going to see when you have a burn question. Third spacing is what happens when there's a burn because, and if you see it here, it says, is a continuous leak of plasma from the vascular space into the interstitial space. That's what causes the electrolyte imbalance and low blood pressure, okay? Now, what's important is if you have a burn patient, do you get an IV? How many IVs do you get? What size needle do you use? We have to think of it. But it says initiate IV access using a large bore needle. Excuse me, using a large bore needle. Oh, sorry. If the burn covers a large area of the body, the client requires insertion of a central line or an interosseous catheter, which is sometimes where they drill into the bone and get fluid right into the bone. When you look here, it says fluid resuscitation meets individual client needs. The total body percentage of burn depth, inhalation injury, associated injuries, urine output, cardiac output, blood pressure, status of electrolytes. Those are all things that you're going to watch for. Now, this is going to be important, okay? We're going to talk more about this. But it says administer half of the total of 24-hour IV fluid volume within the first 8 hours. So what you're going to do on this test, you're going to figure out the total percent of body burned, and then you're going to figure out a fluid amount for the whole 24 hours. Then you're going to take half of that number and you're going to give half of that amount of fluid just within the first 8 hours. Then we're going to take the other half of that fluid and we're going to give it the remaining volume over the next 16 hours. That's an important fact, okay? You got to know that. So what I would do is write that down and make sure you know it. One of the things we're going to give, and it says we're going to infuse isotonic crystalloid solutions. So we have to think that's our 0.9% sodium chloride, right? And that could be our Lactaid ringers. That's not going to shift fluid from compartment to compartment. It's going to stay right in the vessel. We also may have to give a colloid solution. Remember, a colloid is a volume expander. And when you're looking at a volume expander, albumin is a volume expander. It has such a large protein that it can't shift out of the vessel. And so what it's going to do is it's going to expand the volume and bring the pressure up in the patient's body. After the first 24 hours of burn recovery, that's when you're probably going to see a colloid given, which is a volume expander. So we're going to monitor vital signs, obviously, but look, we got to watch for fluid overload, right? And it says, how would you, what are the signs and symptoms of fluid overload? Obviously, edema, neck vein distension, ready pulse, lung crackles, those kind of things. Weight, the way the client daily is going to be important because this is a fluid issue. We got to look at fluids. And remember, 2.2 pounds is 1 liter of fluid. That goes all the way back to another test you had. We also have to look at urine output, and it says we need to ensure an output of 30 mils per hour, okay? So that's really what we want to do. And then we are probably going to have to give some blood products to the patient. So these are nice, just little things that you're going to know. And I'm going to go back over it here in a minute. We're going to pinpoint some things. So monitor for shock. Obviously, you guys know that whenever anybody goes into shock, it's massive vasodilation, right? And it can be caused by different things, but this would probably be due to fluid loss or blood loss, right? And so we got to make sure that we have uh, 30 mils of urine out. If we don't, we're probably not having enough fluid because we're, maybe vasodilating and it's not getting to the kidneys. Shock, and even with the burn, the body will quit regulating the temperature. And so you might see a fever spike. And if you see rapid elevations in temperature, could be shock, decreased bowel sounds, and then blood pressure average very low, um, which just are signs and symptoms of shock, right? If urine output is below the expected reference range, request a prescription to increase fluid replacement. Just nice to know there. Let's look at comfort management, okay? We're going to look at that. Avoid the routes other than IV during the resuscitation phase to decrease absorption from other routes. Okay. Now, this might be what can we give the patient for the pain? Now, remember when I said there's different kinds of burn and you'll have pain with superficial burns, but when you get down to that full thickness burn, you won't have pain anymore because it burned through the nerves. And we talked a little bit about that. And luckily, I'm recording this so you can go back and watch this. But use IV opioid analgesics. One of the most common ones is morphine for a burn patient. Okay. So if they ask you what was a common opioid, it would be morphine. We are going to watch for respiratory depression on top of that smoke inhalation when we give morphine to the patient also. This is a good time to put the patient on a PCA pump, right? So that they can push the button themselves if they're capable. And then it says administer pain meds prior to dressing changes. Those dressings will stick to the patient's tissue, and it could be very painful depending on what kind of burn. So let's see what it says. Use non-pharm methods for pain, guided imagery, music therapy, therapeutic touch. Sometimes that can help along with pain meds. Provide a restful environment and non-painful touch to help increase comfort. Involve the client in the decision making, obviously, and provide relief from itching that can be highly stressful. Um, Oral antipyretics keep skin lubricated. None of that I think will be there. But here is what I think. What are they going to be able to give the patient to give them some type of pain med or comfort? Would be morphine. Okay. We still have to watch for respiratory depression with that. Don't forget, a severely burned patient is unable to control their body temperature. Okay. With skin injury, the body loses heat, decreased temperatures can occur in the first few hours following a burn injury. So what they're saying is that within the first few hours, the patient can get very, very cold. It says for decreased temperature, use warm, inspired air, a warm room, warming blankets, warmers for infusing fluids. So when we put the fluids in there, it may warm them up a little bit. Keep the wounds covered and work quickly. Usually they'll put a clean white sheet just on top of the patient. Low-grade fever can occur later after the first few hours following an injury. And it says, and the temperature can remain increased for several weeks. So at first, the body temperature will drop because they can't regulate it. We might have to warm things up, and then the body temperature will start to rise. But if it starts to rise really rapidly, we might see shock. The GI system, just want to mention this here. It says clients might need an NG tube to reduce the risk of aspiration or to decompress the bowel, right? What usually happens is sometimes it's a shock to the system and the nerves in the system, the GI tract will slow down or sometimes stop moving. They might experience what's called gastroparesis or vomiting. All right. Monitor stool vomitus and gastric secretions for blood. And then it says assess hypomobility, poor tolerance of feedings. But there's something I want to mention here. Let's see if it does. I don't, we were talking about something earlier, and I'm just going to say this. It doesn't say it here, but be aware that if you have a burn patient, there's a very high probability that this patient could have a GI ulcer from the stress on the body. right? There's something called a Cushing's ulcer and a Curling's ulcer. Can't remember which one is for the burn, but there could be a GI ulcer, right? And so they might be on a PPI. They might. Now, with the urinary system, look what happens here. It says monitor for red tinged urine. It could be damage to red blood cells or muscles. Glycosuria. So they may overproduce a lot of sugar here in response to this burn. Remember, their sugars are going to be higher, so they may pee sugar. And this is even if there's no diabetes. This is just a person in general. The big thing with a burn too is infection, because now you remember your skin is your protection and now you don't have that skin anymore. So we wouldn't allow plants or flowers in the room because they carry a lot of bacteria. And it says they carry Pseudomonas aeruginosa, whatever that is. It sounds terrible. It says check the facility policy regarding consumption of fresh fruits and vegetables. So maybe even limit those because they have bacteria. Limit visitors. You wouldn't want sick people coming in. This person is definitely immunocompromised. Monitor for manifestations of infection. And then probably going to keep blood pressure cuffs and thermometers in the room and not take them back and forth to other patients. This is a big one. I do think this will show up because most people won't know that. You administer tetanus, a tetanus toxoid to the patient when there's a burn injury, okay? Administer antibiotics to treat the infection. And look what it says, monitor peak and trial levels. So if that tells you anything, there's only like 1 or 2 meds you would monitor peak and trial levels as far as antibiotics go, and they'd probably be a mycin drug. So we're probably going to give them a powerful antibiotic. It doesn't say that here, but just know. We're going to do strict asepsis with wound care. That means sterile technique, right? Let's look at our nutrition because I'm just going to say this. When your patient is severely burned, their metabolism is speedy, okay? So a loss of 10% or more in body weight indicates a need for additional calorie intake. If you have a large burn area, it creates a hypermetabolic and hypercatabolic state requiring at least 5,000 calories a day. That's a lot. That's a lot. Caloric needs double or triple 4 to 12 days after the burn. So their metabolism is really going to be high. Increase caloric intake to meet increased metabolic demands and prevent hypoglycemia. So eventually the sugar is going to come down and we want to prevent them from having low blood sugar. But remember that we need to increase protein because protein it creates new cells, right? And so protein is responsible for producing new cells and healing. And so make sure we increase that protein, and you can have it says provide high carbohydrates to decrease protein catabolism. So what they're just saying is, the more protein we eat, we might be peeing protein. So we're going to also give high carbs. Decreased gastrointestinal motility, increased caloric needs require enteral therapy or total parenteral nutrition. They may end up, because they need so many calories, having TPN, okay? Just so that you know. And then we're going to make sure we count their calories. That could be a question. And what I think could be is that you just need to know that they're going to be in a hypermetabolic state and they require much more calories than you think. They require more protein, more carbohydrates, but 5,000 calories a day, right? That's a lot. So restoration of mobility, sometimes they'll get where they can't move because their body is burned, right? And they'll get contractures where the muscle will tighten and the skin will tighten. And it just says we're going to splint the extremities and facilitate position changes to prevent contractures. That's something I think I would remember when there's a severe burn. We've got to do passive and active range of motion exercises with the patient, which is probably going to hurt, to prevent everything from becoming very tight. Assist with ambulation if they can, and then apply pressure dressings to prevent contractures. I don't know if any of you have ever seen a pressure dressing like on an arm of a patient who's had a burn. There's like a tight, almost looks like a Ted hose sleeve that they put on their arm. And that keeps everything from contracting and being stiff. And then we've got a watch pressure source. So I think that you wouldn't have any problem guessing that we're going to have to support the patient and the family when there's a severe burn. And they're probably going to have anti-anxiety meds. I don't know about you, but if I had a big portion of my body burned, I think I would have a tremendous panic attack, right? Well, even not even knowing if you're going to live. So we might have to have some of those. Now, do I think they're going to show up with medications? I don't know because I haven't seen the blueprint yet. But I do want you to know that silver, there's medicines that they do apply to burns, and it's not silver like silver jewelry, but this is called silver nitrate or silver sulfasalazine, right? These are burn treatments or medications that we can put on a burn. Now, if you look at silver nitrate, it says apply with gauze dressing, but look, it helps keep fluid from evaporating. It is considered bacteriostatic, which is almost wonderful in the fact that it gets rid of bacteria. And this is kind of inexpensive. But when we're looking at a burn, there is something called eschar, which is dead black skin, and this silver nitrate won't penetrate that. So we're going to have to remove this dead black eschar. Okay. It can stain clothes and it can deplete sodium and potassium. I don't think you need to know all that, but I do think you would need to know what medicine can you give a burn patient. Now, if you look at silver sulfasalazine, look at this. We can do a thin layer on the wound, and it says usually pain-free, effective against gram-negative bacteria and gram-positive and yeast. So both of these are going to try to prevent bacteria and even yeast from forming in the wound. And it says can cause transient neutropenia, which lowers white blood cells, right? We also have to ask if they're going to get sulfasalazine, then if they're allergic to a sulfa drug, right? Um, okay. I just don't know how much of that they're going to ask on this. This one I have not seen, mufenamide acetate. I don't know that you'll get that, but just know there is another medicine. Look at this one penetrates eschar, so it can go down it below the black skin, and then polymyxin B bactracin. There's just some gentamicin topical, and these are all. This one is here an aminoglycoside. Uh, so if they ask you for an antibiotic, I'm going to say gentamicin. It's probably what they're going to give. Okay. But remember, any mycin drug, although this doesn't have MYCIN, it is still a mycin drug. Got to monitor kidney and hearing loss and be aware of that. Mannitol is the big man of diuretics, right? It says use following some electrical burns when obstruction of the renal tubes with protein myoglobin hinders urine output. So if there's a test question where they're not peeing because of an electrical burn, we may have to give them something to help them pee. And then the anti-anxiety drugs, right? Remember, don't put butter or lotion on the wound that has petroleum in it. So, wound care, okay? I do think you're going to get a question on wound care, all right? If you're going to go in and mess with somebody's burn wounds, you better pre-medicate them with an analgesic. And sometimes that would be morphine. I think in this case it would be morphine because I don't think a Tylenol or an NSAID is going to cut it unless it's like ketorolac or something like that, right? So what you're going to do is you're going to remove all previous dressings and look for odors, drainage, and discharge. Assess for sloughing, eschar, and bleeding. Sloughing is like yellow stringy it's like yellow stringy substance down in a wound. It's called sloughing. And then eschar is like the black dead tissue. Okay, so we're going to assess for those when we clean the wound. It says cleanse the wound thoroughly, removing all previous ointments. So we got to get in there and clean it all out. Now, the hard thing to do is mechanical debridement. you're going to have to go in and maybe even use, and it doesn't say here, wet to dry dressing or something like that, but it says use scissors and forceps to cut away the dead tissue during the hydrotherapy treatment. So mechanical means we're actually going to get in there and get rid of the dead material. And then hydrotherapy is they're going to get in a warm tub of water and cleanse the wound, and they're going to use mild soap or detergent to wash burns gently and then rinse. Uh, Keep in mind, I'm sure it depends on the type of wound that you're going to deal with, but they need to exercise their joints while they're in the hydrotherapy. Chemical, obviously, there's a chemical debrider that you can put down in the wound, and it's a topical enzyme that breaks down and removes dead tissue. It says apply topical enzyme agents to the wound during a daily dressing change. So you can use mechanical, hydrotherapy, or chemical. Now, this, I'm just going to say eschar-ectomy or otomy, excuse me, is just removing the dead black skin that builds up, and it's going to help improve the circulation. You guys, we already talked about a fasciotomy. You know, we can't rule out compartment syndrome in a compartment on this either. So a fasciotomy where we cut down and make relieve the pressure. And then there's going to be different kinds of skin coverings that we can put on the patient. And in times past, I'm going to say I have seen these as test questions. Although on your didactic, let me see what it says. Review type, severity, injury classification, burn, depth, staging. We kind of did this. See, and this is conditions needed for wound healing and scarring with burns. So this may show up what can promote healing of a large burn, right? Well, skin coverings promote retention of water and protein and provide coverage of nerve endings and reduce pain. So when you're dealing, and I actually have seen this as a board's question, so I know that you do need to know this, but if we look at an allograft, that means we got it from someone else. If we had an autograft, that means we got it from ourselves. But an allograft says skin donations from a human cadaver, partial and full thickness burns. So they will take skin, a donation from someone, and then cover the burn wound. And really, truly, what it is, I don't know if you've seen it, if you've seen anybody with a burn, the skin is cut into like a square, and little slits are made in the skin so it's kind of stretchy. And so as the skin starts to heal on the patient, you might see little hole type things in that. A xenograft is from an animal. So like a pig skin is often used, and it's called a xenograft, okay? Um, I have not seen any of the other ones. Amnion, it says from human placenta. I haven't seen that on a question. Cultured skin, epidural cells from unburned area, or artificial skin made from beef collagen and shark cartilage. I have not seen those, but allograft and xenograft may possibly show up. If we look, probably to help heal this wound, we're going to have to graft the skin, right? I'm going to skip down to the one I think here. And if you look here, this says autograft. That means they got it from their own body somewhere else, right? It could be a sheet, it could be like a mesh graft. It has little small slits in it, so it can be stretchy. And then just know that autograft means that they got it from the patient. Okay. Um, let's see here. I'm looking discoloration of unburned skin, green subcutaneous fat. It says keep the extremity elevated, report manifestations of infection, perform range of motion exercises, and then observe wound for infection. I really think they're going to talk about surgical debridement, removal of thin layers of necrotic tissue until bleeding occurs. So what they're going to do, and this is why that's so painful, is they are going to really dig off the dead tissue, the eschar, until they get blood. And then that blood is going to help bring in viable tissue. And it says can be replaced throughout the restoration process. So just know that's going to be kind of painful. But if it's burnt through the nerves, then maybe not, right? And they can do reconstruction on the person also. I'm gonna just kind of look at this for just a minute because I don't know if you need all of it. Um, so, once again, it says in the acute phase, it's common to experience anxiety and fear. Yeah, we might have to give them like a benzo or something like that. And then look, wear compression. So I've seen a question before about wearing compression dressings and garments as prescribed. They usually want them to wear them 23 hours a day and then take them off for 1 hour. And this helps minimize scarring and prevent uh, problems with mobility. Okay. So don't put tight clothing over burned areas, loose fitting clothing, splints, assisted devices, follow-up appointments, those kind of things. But one of the things it talked about with pressure dressing is how to wash them and how to maintain them. And you just very lightly wash them and you very lightly hang them to dry. You don't stretch them or anything like that. Airway injuries is something that is huge. Okay. Remember, the airway, we have to think of the airway in a burn injury. If the injury took place in an enclosed space, suspect carbon monoxide poisoning. Now, that's exactly what I think they're going to go for. They may say their oxygen level is 95, but you've got to check carboxyhemoglobin, which is a blood test to detect the carbon, which it says if it's greater than 10, they have carbon monoxide poisoning. Look, effects might not manifest for up to 24 to 48 hours. And then you might see edema in the airway, like hoarseness, a brassy cough, difficulty swallowing, drooling, secretions, maybe some adventitious breath sounds like stridor and wheezes. Okay. So we got to do airway management. Another big thing is fluid imbalance. This is the huge part of a burn. Hypovolemic shock is possible with inadequate fluid replacement. That's why you're going to have to use the Parkland burn formula. Okay. So excessive or rapid replacement can also lead to hypervolemia. So we got to be very careful. Monitor for inadequate perfusion, hypotension, decreased urine output. And then it says monitor for too much fluid, right? Lung crackles, persistent edema. So we're going to monitor for both. Sepsis, we know, and we've talked about that, sepsis or septic shock, but we know that sepsis is a bacteria that can enter the bloodstream and then it causes this massive vasodilation, right? So we've got to be careful and administer our antibiotics. And one of them was gentamicin that we read there. And then we got to make sure that they don't get contractures, right? Like we still need to do that active and passive range of motion with the patient. And then compression dressings can up for 24 months to reduce scarring. So that's a long time. When we look here, compartment syndrome, just like I said, may have to do a fasciotomy. And then remember we said something about gastroparesis, where the GI system kind of shuts down. But paralytic ileus means that the small intestine stops being mobile. And so if we see paralytic ileus, we could have a systemic infection. And then I don't know about you either, but post-traumatic stress disorder certainly can play a role in this. I don't know anybody who would go through a severe burn and not have some type of stress disorder. So what I'm going to do is I'm going to stop the video, and then when I restart it and we talk about the rule nines, then I'll get back on here. But hang on just a minute and let me just pause this for just a minute. Okay, so we answered a couple practice questions, and I just went to my little review sheet I made last semester, and I like the visual of this that and I want to point out something to you because I do think that they'll ask this. When you have a superficial thickness or even a partial superficial thickness, it does it a little bit different here. Then this is painful. I don't know if you noticed here, it says painful, no blister. This is more painful. It has a blister. And sometimes these blisters weep and ooze, right? And this is like a deep partial thickness. Look, it goes down into this dermis area. And it says forms more scars and less painful. But some of the times they may ask about pain. When would the patient feel pain? And they may give you like what kind of burn they had. Okay. So if we look, I want to see here. Oh, it doesn't say, but that's why I like the one that's in the ATI book. Because when you get over here to some of these full thickness and fourth degree, there's no pain. Go back to the ATI one and find out which one is no pain, because what that means is it's burned through all the nerves and all the tissue that carries any type of feeling, and you don't feel it anymore. Okay. You would still treat the patient because with a like morphine or a pain med, because the, you know, you're going to have other ends of tissue on either side of this burn that can still feel pain, right? But the actual burn itself won't feel the pain. There, if you look in your Pearson book, which I would recommend to do this, and maybe what I'm looking for is in here. I want you to see a superficial burn is only the epidermis, right? And it says it in the ATI, pink to bright red, and it said might slight edema, heals in this amount of time. Maybe need a little mild analgesic like a Tylenol or something. I would say this would be a sunburn, okay? And then, did it say IV? IV fluid may be required. It's a possibility. So look at your partial thickness, and it says a blister may form. Um, that's usually what you're going to think of when you think of that specific one. And then here's the blister formation again. I just repeated it. And then they have a little section in here that says, what is a superficial burn? And it actually really like listed out, what it is, UV light or sunburn. And we saw that one question in the ATI book that talked about that. And, what color would it look like, and what kind of treatment would you give? A mild analgesic, or probably rinse it with cold water. Remember, never put butter or any kind of petroleum jelly on a burn. Don't do that. That could be a question. So if we have a deep partial thickness, look, both the epidermis and the dermis are affected and probably going to have some blisters. And then if you look over here, it doesn't say anything about nerves. Let's go down here and see if it does. This one says burns may require more than 21 days. Oh, contractures are possible. Scarring is possible. I don't think they'll ask about that. And then, of course, we read about this, and it says there's probably blister formation. Pay attention to redness, blister. And if you look here, a partial thickness burn, look at the blisters on the feet. That's why I pulled this up and just kind of took a screenshot of it. Um, know what a contracture is when you go into this test. When you have a deep partial thickness wound, uh, the connective tissue that actually is underneath the skin can tighten really tight. And it says it can contracture or cause permanent shortening of the connective tissue. And then, of course, severe scarring, and then maybe even loss of mobility. That's why they use pressure dressings on them. The full thickness, okay, I'm going to look here, may require application of topical agents. We talked about those would be like silver nitrate, silver sulfasalazine. There was a couple other ones I hadn't seen before. And then it says, look, sensation to pain and light touch is absent at the burn site. So with a full thickness burn, you probably have burn through the nerves, and you're not going to have pain at the burn site. Probably going to have some skin grafts too. So when we go down, you can kind of see this is more like a full thickness burn. And you can see this in your Pearson book. But let me go down here and see. One, I do like this picture that's in your book, because when you have this burn, look at this full thickness burn. Look at all that has been burnt through. We burnt through a fatty layer. We burnt through hair follicles. We've burned through nerve endings, which are in the dermis. We've also burned through muscle and down into the bone. And so it makes sense that you wouldn't have any feeling there. Now, look at this. We just talked about this. Opioids should be administered intravenously in an emergent or acute stage of a burn because of decreased circulation and absorption of meds, right? So let's give them IV opioids. And one of the things it said was morphine, but one of the test questions said fentanyl too. The most common one is morphine. Now, a long time ago, it says describe the 6 degrees of burn depth. That's exactly what we just did. We went over like what does it look like, and really truly, um, if you look, it just says fourth degree, you've gone into the fat, fifth, you've gone into the muscle, and sixth, you've gone into the bone. I don't know that you have to know much more than that. But if you look here, I want you to see what they really wanted to focus on last time was 5 potential complications after a burn. Remember how I just asked you, I said, what are some things you would be worried about if you were treating a burn patient? And one would be severe dehydration, right? Another would be infection, and they already had those listed. But remember, we're worried about respirations. We're worried about carbon monoxide poisoning. We're worried about an inhalation injury. We're worried maybe that the heart can speed up because potassium is going to go up. Their sugars are going to go up. So we just need to go into the test knowing what to really look at. Um, we watch for wound infection, obviously. It just talks about there's a safety alert I wanted to look at here. High levels, okay, here it is. High levels of carbon monoxide in the bloodstream can skew the pulse oximetry readings, giving the appearance of adequate oxygenation saturation in patients with hypoxia. Make patient assessment your primary data source. Do not rely on monitors as a replacement for an assessment. So essentially what this is saying here is carbon monoxide poisoning won't show up in a pulse oximetry reading. It may look like you have adequate oxygenation because we're looking, is the patient's oxygen good? But it says they could even be hypoxic, even with their oxygen at 95, and they certainly could have carbon monoxide poisoning. And then it says administration of IV fluids to restore the circulating volume. Okay. Now we're going to get to, and I'm going to have you, when we do this, I'm looking for the one, I think it's in the next one, the very next slide, because I looked at it earlier. Fluid resuscitation. Okay. You're going to have to resuscitate the fluid of this patient. The American Burn Association's practice guidelines recommend formal fluid replacement for any patient with a non-superficial burn wound, obviously. And what I'm gonna do is skip right down to here. It says, according to the Parkland burn formula. Okay, so then I'm gonna go down here. And I want you to write this down because I know that they're probably gonna have you figure out how much fluid to give the patient. And here in a minute, I'm going to ask you a question. These formulas provide guidelines for volume of fluid to be infused over the first 24 hours. Okay. So what I want you to see, it says the Parkland burn formula, adult requirements during the first 24 hours. And here is the math. Okay. You do 4 milliliters times the total burn percentage of the body, total body surface area burned, times the patient's weight in kilograms. Okay, I'm going to have to write this down because it's been a minute since I did it. So make sure you write that down. Okay, 4 mils times the percentage of total surface body burn, and then the weight in kilograms. Okay. And it says with 50% of the fluid being infused in the first 8 hours. So what you'll do is you'll do 4 mils times the total percent, whatever it is, and then you're going to do times the weight in kilograms, and you're going to get a number. Then you're going to take that number and you're going to take 50% of that, half of that number is going to be given in the first 8 hours. And then the other half of that fluid is going to be given in the next 16 hours. Okay? That's important. So make sure you know that when we talk about this here in a minute. It says pediatric patients with burn injuries require a different approach. So this is more just the adult, and I don't know that they will ask you on the pediatric patient. But one thing I do want to point out too is that hourly urine output is considered the most effective indicator of fluid resuscitation. So you're going to be watching the urine output to see if they're getting enough fluid. All right. In adult patients with burn injuries, urine production is 0.5 to 1 mil per kilogram per hour, which is approximately, 30 mils per hour. If you want to, when you're working in the ICU or the burn unit, they get really specific. 0.5 to 1 mils per kilogram per hour. Okay. But we want to make sure they're at least getting 30 mils per hour. And it did say this in the ATI book too. Patients who sustain electrical burns often have injuries that are not visible, making the extent or volume of tissue damage difficult to assess. It says conventional fluid resuscitation formulas may probably not work on them. So just be aware of that if that happens. Okay, so let me look here. I'm just going to look. Okay, so I want us to see. Let's read this, and I'm going to point something out again. I'm going to drill it into your brain. The pulse oximetry says allows for continuous assessment of oxygen levels, right? Except in patients with carbon monoxide poisoning. For these patients, pulse oximetry readings may be falsely elevated because of carbon monoxide that is bound to hemoglobin. So it's kind of hiding in there. So we have to get a carboxyhemoglobin measurement may be performed using venous or arterial blood measurements, the percentage of hemoglobin that is bound to the carbon monoxide. That's going to be your most accurate measurement for carbon. Then we're going to do ABGs. And remember, it said that the patient who has burns is probably going to have metabolic acidosis. Remember, that's like the worst ABG you can have. And then let's look here. It says we're going to do ECG because remember, there could be some dysrhythmias in the heart due to, look, uh, should be hyperkalemia, which because the potassium will be high, right? We may have to do chest x-rays to check for fluids in the lungs or collapsed lung. And then obviously urinalysis to look at. I'm going to point one thing out that wasn't mentioned. It was mentioned, but I didn't think you would catch it. But when you have trauma to the body and trauma to the muscle in a burn patient, the muscle, it's almost like rhabdomyolysis that you have heard about before. The muscle will release this myoglobin and it will cause the urine to turn dark. It's really rhabdomyolysis, and it says myoglobinuria, which manifests as dark brown or wine-colored urine, signals the development of acute tubular necrosis. And then it says glycosuria is also a transient development, which means they may see an increased sugar in the urine. So those might be important there. Remember, we may have to look at a CBC, electrolytes, renal function. The bun will be up because of the dehydration, right? And then don't forget, we're going to probably have to give them protein, and albumin is the volume expander to help expand volume there. And then blood glucose is elevated. So I just kind of, let's see here. I do want to do safety alerts because those sometimes show up as questions. An increase in body temperature without other manifestations of infection does not indicate infection in a patient with a large burn. It could be septic shock, probably. It says because their hypermetabolic response resets their core temperature to a higher level. So remember, they're going to go higher in their temperature because they're in a hypermetabolic state. But remember what it said is if it rises too fast, it could be shock, right? And so we have to watch for that bacteria there. Okay, so let me go on. I think we've covered everything here. And it says, which subjective would you need to be collect, and then what is the objective data? Let's go here. Rule of nines. I wonder if chapters, I don't know. I'm going to look at this. We'll go to ATI page 499. Let's just go there real quick. Okay. Let's see if we can go to 499. I don't know if it's in this chapter. 499 burns. Okay. Hmm. Well, it just talks about that percentage. Let me go back down to this because we already saw that. And then 509. I think we've seen that. So I'm gonna go on. Now, here is I'm gonna scrunch this down and I'm just gonna give you this nice little diagram here. Let's see if I can. Oh, well. You guys look at this part of the screen here. When you have the Parkland-Burn formula, there is something called the rule of nines. And guys, I think y'all will get a worksheet. If I'm not mistaken, I don't have the worksheet unless I just didn't see it. But you'll get a worksheet and it'll say the front of the head was burned, the front of the face. That would be 4.5. So 4.5% for the front of the face, 4.5% for the back of the head. 9% for the upper torso, 9% for the back of the upper torso. If you had the full trunk, it would be 18%. Look, 9%, 9%, that's 18%. Same with the back. So that you have to really pay attention to what the question's asking you because it will say so much of this was burnt, this and this and this, and then you've got to figure out. So if we said the front of the face was burnt, we would go over here and put 4.5%. And if we said the upper torso, we'd put a 9. And then maybe it would say the left front of the left leg. That would be 9. Okay. So what we would do is we would add those together and we would get 22.5%. Okay. So that's how they're going to ask the question. They're going to say, this was burnt, and you kind of have to have a visual in your mind. They don't give you this picture. You have to have the visual of what percentage of the body. So the front of the arm is a percentage, the back of the arm is a percentage, the front of the leg is a percentage, the back of the leg is a percentage. The groin even has a percentage, 1%. Okay. So what you're going to do is you'll add the percentages, and I'll try to find a question that will help you with this. Then you're going to take that formula that I just told you, and you're going to do 4 mils times the total burn percentage, right, which is 22.5, which we got here. And then from the question, it said the client's weight was 42 kilograms. Okay. So when we got this, what we came up with was 3,780. That is how much fluid you are going to give the patient within the next 24 hours. Okay. Then what you're going to do is you're going to divide that by 2. This whole number, you're going to take it and you're going to divide it by 2. And when you divide that, you're going to end up with 1890. Okay. You're going to give 1,890 mils in the first 8 hours. That's 50% of that fluid. And then over the next 16 hours, you're going to give another 1,890 mils. I will see if there's some practice questions on that, but that is what the Parkland-Burn formula is. And if you look, it says rule of 9 for burns. Look, entire head and neck. If you had the whole head and neck area, that's 9. If you had just the front of the head, that's 4.5. So we have to look like the entire trunk, like all the way, that's including front and back and groin. So we got to really pay attention to these practice, to the way they're asking this question. And it just says the rule of nines is a quick method of estimation used during the pre-hospital and emergency care phases. Remember, we got to get that fluid in there, and we've got to get, and I'm just going to say 2 large bore IVs. Although I didn't see it in the ATI book, I would say it's there. And right here, this is for children, I think. This is the adult one. I don't think I would worry about the child one. I didn't say anything about it. but it just kind of shows you here the age for children and adults. And then let's look down here. I'm just going to look. There's the Lund-Brauer, a burn assessment, which I don't think they'll ask about that. I've never seen one that they've asked about that. But just know that there is another assessment that exists, right? And so let's see what we've got here. That's it. I'm going to pause this for just a minute and see if there's any questions.